Okay, so today we're going to examine some of the drugs that are used for the management of ischemic stroke. Only two learning objectives. There's only two drugs. So what is stroke? Well, it's a reduction in blood flow. We know that. And you can characterize it by a neurological deficit. And this deficit may last anywhere from just a few hours to more than 24 hours. And of course, it's vascular in origin, the size of which basically determines the amount of damage to different regions of the brain. And just of note, TIAs, or transient ischemic effects, are basically kind of what's termed mini strokes. And these can be less than 24 hours, and they affect around 200,000 patients yearly. But in terms of therapy or management goals, the main goal is to reduce the ongoing neurological injury. We'd like to decrease mortality, of course. Then the other thing is we want to prevent brain damage. We would like to see a return of normal blood flow to the regions of the brain that have been affected. And of course, we'd also like to prevent another one from occurring. And so in terms of treatment of ischemic stroke, we're looking at really two different modalities. One is drug, and IV Alteplase is that drug, and then the other is thrombectomy, which will be covered by another discipline director. IV Alteplase, also known as TPA, is best given within about 4 hours of the initial onset of symptoms of a stroke. And the criteria are pretty straightforward. Blood pressure must be lower than 185 on the systolic side and lower than 110 on the diastolic side. The patient must be over 18 years of age and, of course, not pregnant. And, you know, the main reason in terms of the criteria for blood pressure really stems from the fact that, if the blood pressure is too high and then you give Alteplase, and I'll show you how that works in a minute, the patient can bleed out. And so that's one of the major things that you have to kind of watch out for so that these patients don't bleed out. So, and then the other drug that's used in the management of stroke is aspirin. And that's pretty much a standard therapeutic modality is, after these patients experience the stroke, aspirin is really best given within about 48 hours of that stroke, basically once they've stabilized. But, sorry. And so Alteplase, let's return to Alteplase, the main kind of star of the show here, also known as TPA. And this is a serine protease that basically cleaves these fibrin molecules. And Alteplase is kind of like the second generation drug. Streptokinase and some of these other ones have been used historically, but we don't use these drugs. The grandparent molecules, streptokinase and urokinase, for a variety of reasons, efficacy, side effects, allergies, and so forth. Alteplase is really now kind of like the standard therapeutic approach for these patients, and so that's why I've really narrowed this list down to the one drug we use. It's got a very short half-life, anywhere from 5 to 30 minutes, depending on the patient. Of course, this is administered IV. And it's really most effective when given within 3, maybe 4 hours of a stroke. You can see different reports, and we need imaging studies to demonstrate that there's no active bleed. Of course, that'd be the biggest contraindication. Other generations that came after Alteplase, Reteplase, and Alteplase, these are higher affinity, many of which have longer half-lives. They're also more expensive, and the clinical data has been somewhat conflicting. In many cases, Alteplase, and according to the American Association of Neurology, Alteplase is still kind of the favored drug. And maybe you can see that recommendation switching over the next couple of years as these drugs get newer and improved. But right now, it's Alteplase. The major side effect, of course, is systemic bleeding, especially at the higher doses. And you must monitor the blood pressure both during and after administration of this drug. So how does it work? Well, in patients that have stroke, MI, pulmonary embolism, DVT, basically we have a situation where you have low oxygen perfusion. Okay, and of course this kind of feeds into this plasmin pathway. When plasminogen, which is one of the precursors, is activated, and it can be activated by alteplase, which is this recombinant TPA. Plasminogen gets converted into plasmin, and then this basically assists in fibrin degradation. And so fibrin is one of those key molecules that dissolves the clot. And so when this pathway gets activated, the outcome is degradation of fibrin and restored oxygen perfusion. And so we'll go into much more detail of the physiology behind this in the hematology block, of course. But essentially, this is kind of a bird's eye view of what we're looking at here. When fibrinolytics such as alteplase are used, we see an activation of the plasminogen pathway, resulting in fibrin degradation. And then from a physiological standpoint, we see restored oxygen perfusion. So of course there are complications or side effects to alteplase. Patients can of course bleed out. There can be an angioedema production. You can see breathing complications and airway obstructions occurring, and of course that would need to be managed immediately. Alteplase should be stopped if there's an active bleed, if the patient complains of a severe headache, if the hypertension or if hypertension resumes or is uncontrolled with drugs, if the patient demonstrates a worsening neuro exam, and of course if they become nauseous or start vomiting. Aspirin, we said, is kind of the gold standard in secondary stroke prevention. Officially, we know it's a COX-1/2 inhibitor, and we're basically inhibiting the COX pathway, which is basically specific to the platelet and the clot. Low doses, 162 milligrams per day, kind of favor inhibition of COX-1 moreover than COX-2, and we talked about that in a previous block. But the key in terms of these stroke patients is really preventing secondary stroke. And so patients with a history of stroke or TIA, they have a much higher risk of having another stroke. So many of the comorbid diseases, hypertension, hyperlipidemia, MI, AFib, arteriosclerosis, all of these need to be treated, and they need to be treated and managed aggressively. Otherwise, these patients are going to have another stroke. They're going to come back to the clinic, possibly with even more neurological deficits. And of course, some of the secondary treatment strategies include managing these diseases. And so the appropriate drug classes are basically shown as the kind of preferred treatment modality for each of these diseases. And of course, we haven't really gone into a lot of the coagulation type pathways. We're going to kind of reserve these drugs for the hematology block, which is next year. We don't need to cover all the drugs the first year of medical school. So we're going to table some of these warfarin, some of these newer oral agents and so forth. And we'll talk about aspirin again, and we'll also talk about some of these other drugs that have antiplatelet effects. And so what we've been talking about basically has been ischemic stroke. Understand that there's also hemorrhagic stroke. These are less frequent. They're characterized by an active bleed in the brain, of course. And so the goal is actually the opposite. Now the goal here is to stop the bleeding. And we can accomplish this by using mannitol, the osmotic diuretic, or anti-seizure medications. And so, of course, these medications will be covered in other courses where appropriate in other cases. But I just wanted to draw your attention that there are some drugs that can be used for hemorrhagic stroke. But the whole basis of this particular lecture was really focused on ischemic stroke. Okay, so any questions, please let me know, and enjoy the rest of the week. Thank you.